Hey, what's going on? My name is Dr. Ben Glass. I'm a chiropractor. This is the Pre-Chiro podcast where we're aiming to contextualize this path to become a chiropractor and really just provide insight into the different pathways that you can take as a prospective student if you're considering becoming a chiropractor. Today, I have Dr. Katz on with me. Thank you so much for taking some time. And if you could just please introduce yourself to the students and also just share a little bit about what your background was before you decided to become a chiropractor.
Yeah, thanks so much for having me on from one fellow New York East Coaster to another. So I practice in Boulder, Colorado with my wife. Before that, our practice is very, what we like to say, very patient-centered, very patient-oriented, research-based, that I think the research clearly supports the philosophy. During that time, we just built one patient at a time. Never went into the big marketing aspect, and we're as busy as we can be. Since that time, we've published research that I truly believe helps the chiropractic profession a ton, really show why what we do works. We do have a digital motion x-ray that we've had in our office for about 18 years. And we actually just published the largest cervical biomechanical study using motion ever done, comparing injured versus non-injured. And because of that, we're able to really look at and help a lot of patients that have either been given up on or missed or underdiagnosed, and we kind of just built our practice that way.
Awesome. Yeah, no, there's a number of things you just mentioned there, which I would like to go deeper into. But talk about what inspires you to become a chiropractor, or where you were at when you decided that this was the path you wanted to take.
Yeah, so growing up, my mom's brother, my Uncle Jerry, has been a chiropractor for, if I say it wrong, it's either going to look too little or too much, but like 50 or 60 years. Dr. Jerry Whitner, he's actually in Newburgh, New York. And my mom used to take me to him when I was a kid, and I would just feel better, So I never really thought anything about it. It was just the way our life was, right? My mom would take me to her brother. I'd get adjusted. It'd feel great. We'd go to his house and we would just ask, can you adjust me? Just because it felt good. As a kid, didn't connect why it felt good. Mm-hmm. So as I was going through school, trying to figure out what to do, I always just kind of did well in science, but never really thought about a science career until I started really thinking about it. And I looked at the normal route, right? You look at, first thing you think of healthcare, you think of medical school. So I talked to a bunch of medical doctors, and every single one of them talked me out of it. And that's a fact. Then I started looking at dentistry, but I've never had good teeth. And I'm like, I don't want to just look at one body part for the rest of my life. And then every chiropractor and PT that I spoke to loved what they did. And my Uncle Jerry was like, why don't you go to be a chiropractor compared to a PT? It's more schooling, but you could do what PTs can, and PTs can't do what you can. So why not just do that? So then I was like, it kind of hit me like a ton of bricks, and I'm like, I'm totally going to go do this. And that was it.
Right on. That's cool. So fast forwarding into your chiropractic academic experience, what was it that you naturally gravitated towards being somebody who is a published researcher? Obviously, from my experience, we don't get a lot of specific training on how to publish research or how to do research as a chiropractic student. Can you just talk about what your chiropractic student experience was like, and maybe some of the things that you think students today should be focused on if they wanted to one day do research?
Yeah. So, I never thought about being a researcher. I don't consider myself a researcher. What has happened in our practice was we just saw really cool stuff. And I would see patients that would be, let's say, hurt in car crashes, right? And that's the one time in practice where you kind of really have to explain what you're doing if push comes to shove. Like you get to pose or you go to trial, which I've been to trial over 20 something times. In fact, the last trial we just testified in for what most people consider whiplash. The average jury verdict when I testify is like over 400,000. This last one was $1 million, and I treated the patient 206 times and had to defend 206 visits on stand. And the jury obviously completely understood why. So during that time, I kept looking at the research, and there's so much that validates what we do. But before that in school, I was really lucky enough. I went to Life West, where One of my mentors and person who really guided me while I was in school and pushed me was Dr. Carrie Duggins. And Dr. Carrie Duggins, I would find stuff and I would look and, she would question, well, why are you doing that? And I would say, well, that's a really good question. Like, I'm going to show you why. And she knew why. She was but she would force me to go look it up. And I'd find these studies. I'm like, hey, check this out. This is already published. This explains that. And all I kept finding was in school, people wouldn't really give me an answer, but the answers, what people call philosophy, like, oh, that's my philosophical belief, was like, well, there's already a lot of studies that publish this. So why don't we just talk about it? And then therefore, it's not my philosophy versus your philosophy. It's, hey, here's what was shown. Let's talk about why that actually helps. And that kind of just snowballed where in practice, we kept seeing these, like, I don't know, whether this sounds mean or not. I keep hearing all these chiropractors, like, we have these miracles in our office. And I'm like, well, then publish it. Let other people see, because you telling me is happening it means something to you and that patient, but it doesn't mean anything to us in the profession because we can't explain it. We can't educate. So I got myself around amazing people, other mentors like Dr. Michael Freeman, who, he's a chiropractor. He's a forensic epidemiologist, an MD, PhD. And he'd always push me. Like, I'd say, well, I'm doing this because of that. He's like, well, how do you know that? And I'm like, well, I'll show you. Okay, well, and it just kept pushing. And I kept wanting to see more about what was happening and why was it happening. And then from the patient education perspective, where I just say, look, let me show you this study from here that shows why this problem that we've identified can lead to this in the short term, but also in the long term. And it's amazing how there's so much science and evidence out there that support what we do and support why these issues that our patients have, spinal issues, lead to really bad things. And our profession, what I've seen, seems to, take the shortcut. Oh, that's what we see. Oh, no, it's a subluxation. It's like, well, how'd you find that? What does it mean? And it's great that you think that, and it's great that I think that, but can we show why that actually happens? And there's so much out there that I kind of got to the point where I'm like, the philosophy at this point is now backed up by the research, but so many of us don't look at it or explain it for a few reasons. So I just kind of was like, I'm going to show what we've done, and I'm not going to tell you, hey, I've seen this. I'm going to do it, publish it, put it out there, and then you can go ahead and be like, here it is. Show it to your patients. Show them what we can do, but also show them what's happening to their bodies from a theological perspective, as opposed to, this isn't just my philosophy anymore. This is what we've seen, objectified, and published.
Yeah, and for a lot of prospective students out there, the Dr. Duggins mentor, the Dr. Katz is mentioning, she's really passionate about Gonstead chiropractic and also chiropractic biophysics, which both are reliant somewhat or guided by radiology. And x-rays are something that chiropractic students study when they're in school. And also what you mentioned when you got out, you had some mentors that were MD PhDs. I think that we need more chiropractic PhDs. And I'm hoping that pre-chiro contextualizes that you don't just have to be in practice. You could also be in the laboratory, or you could be in practice, but also contribute to some clinical trials. So can you talk a little bit about, go deeper into whiplash? Because for the average person out there, they're not really understanding how chiropractic is uniquely positioned, or how a chiropractor is uniquely positioned to really help somebody who's been in a car accident. Can you just unpack some of the things, topics to study, or different science constructs that you can help build context for them of how you take care of somebody?
Yeah. So first, and knows this coming with love, it's a car crash, not a car accident. And there's a big difference, right? We want to get these terminology correct. An accident is, according to Mark Rosenkind, head of the National Public Institute, I think out of Harvard, is an act of God. It was unavoidable. Most crashes are done because there was an error. Someone was texting, not paying attention. The insurance companies like to use the term accident because it sounds like it was an accident, but it's a motor vehicle crash. And in terms as it comes to whiplash, that's also a term that is thrown around too much. And like, oh, I have a patient that has a whiplash injury. And I teach this all the time when I present or through my site is I'm like, okay, I don't know what that means. Like the amount of injuries that can occur from a whiplash injury can be nothing and all the way to death. So when you have a patient that has whiplash, it's a mechanism of injury. So then you have to dive deeper and say, okay, what did that mechanism of whiplash cause? Did it cause damage of the ALL ligament? Did it cause damage of the PLL ligament? Did it cause damage to the accessory and alar ligament leading to upper cervical instability? Did it cause a facet damage, a capsular tear? Did it cause a vascular tear? Did it cause a head injury or a brain injury? All those things are under the term of whiplash. But our profession is taught by these quote unquote PI gurus that just teach you these little insurance words that mean nothing in the real world. And they paint us into this corner. So when we look at patients that are involved in crashes and how can chiropractic help, it's, well, what did you find, right? Did you just find, did you write in your notes, they have a subluxation? Okay, well, where's that subluxation? What is that subluxation causing? How did you identify that subluxation? Because a subluxation can be incredibly unstable where it needs surgical fusion to abnormal biomechanics that can lead to things that we can also help. So it's trying to get the info out there to say, here's a ton of different pathologies that can occur from the mechanism of whiplash. And did you identify them, explain what they are? And then how can you treat that? How can you help that? How can you minimize that problem? And that's diving really deep into it. And it adds more work, but for me, it adds a lot more fun because you can really see these true problems and true findings that, we know can occur. I mean, they've shown out of Yale small impacts, what some people think, oh, it's just soft tissue injury, have torn the anterior longitudinal ligament as well as causing vertebral artery elongation and injury. So that's a whiplash injury, but are you saying a potential vascular tear is just soft tissue? Are you saying that an unstable segment that the research has been shown to lead to eventual radiculopathy or irritation of the spinal cord is just no big deal? And they are big deals, and they've been linked to significant long-term disabilities. And then we have to look at is, okay, how does my chiropractic help that? And that's what I always want to teach is like, understand how important and powerful what we can do is, as long as we take the time to really understand what those injuries and pathologies are, how you've identified them, and then what chiropractic care are you given to improve the bad that you found on their spine and how it relates to their health.
Mm-hmm. Very cool. So can we go deeper into what it's like for you on a day-to-day in the life of a chiropractor, how you're expressing your chiropractic or how you're practicing chiropractic? Obviously,
Yeah.
You're mentoring other docs and you're sharing literature and you're contributing to the literature, but can you talk about on a day-to-day what your experience is like?
Yeah. It's always exciting. And we like, some complicated cases, so we do a lot of CBP in our office because we really look at the sagittal coronal planes because they're incredibly linked to bad outcomes. And we want to try to fix those. We can show that we're making a change on pre and post images, as well as how they're feeling and outcomes. So we see a lot of patients that have upper cervical instability. Like true upper cervical instability. We actually submitted a paper that's going to be published where we're going to be the first ones to show ever that based on what we did, we actually dramatically reduced upper cervical instability. The only thing that's ever shown that is surgery. So I can't tell you, and now I can get to the point where I don't have to say, oh, I've seen that a lot. Well, show me. I'm going to show everybody by publishing this that what we do is an option for these significant injuries that are linked to over 50% chronicity and 30% are led to significant disability. So we see a lot of that. We've been getting a lot of patients with brain shunts because their brain isn't, the CSF isn't draining, and we're looking at mechanically why. We published a paper in the Journal of Brain Circulation where we showed abnormal curves on MR angiograms decrease blood flow to the brain. And by increasing the curve, it increases blood flow to the brain. So we're looking at, and MDs, surgeons that have seen our paper are starting to refer to us because they're like, well, if the blood isn't flowing, maybe the CSF isn't either. And we're starting to really look at these patients that have already had shunts. The shunts aren't working, it's not draining. And we're seeing like people that have been incredibly disabled from, it's not like, okay, your cord is being compressed, we're going to decompress it. It's these massive intracranial pressure headaches. It's abnormal mechanics and instability that is causing significant problems. And then we're looking at it as, this is how we can fix this. So patients, we don't have what most people would call a high volume practice, where, I always see docs that are like, I see 100 patients a day. I'm like, that's impossible. I know people are going to get mad at me, but like, come to my office and tell me how you can see 100 patients in a day doing exams to determine if they have accessory alar ligament damage, loss of curves, decreased blood flow. It's impossible. I'm sorry. And people will get mad at me, but I don't know how you can do that with these patients, right? And maybe you just don't have the same patient base as me, and that's totally okay. But we see these patients with significant structural, biomechanical, like true subluxations with significant health outcomes. And of course, we see a lot of athletes. We treat some MMA, and those obviously don't take as long to try to manage and figure out what's happening and really apply the appropriate adjustment to say you have a torn right accessory and alar ligament complex leading to upper cervical instability near the brainstem. We need to adjust it like this. And you can't just feel that with your hands. You have to do an appropriate test and really fit. And those are true subluxations, in my opinion. See on a regular, and we're busy. Like we have we take no insurance. Well, we're on zero insurance networks. We don't really advertise, and we have a patient waiting list. These patients that are suffering and getting them in. And that to me, I'm like, wow, we're not just seeing someone like, oh, my neck hurts. We're seeing like resolution of cerebral spinal fluid drainage that have already had shunts and failed. And we're seeing patients that have been disabled with significant pathologies in their spine start to like get their lives back, and that's like, whoa, it's awesome.
Yeah, no, I've witnessed a wide spectrum of chiropractic approaches to clinical practice. Some chiropractors are just very intuitive. They don't use any diagnostics. It's all about that connection with the person and really just adjusting them, clearing their spine, allowing innate to flow freely. And then there's other chiropractors on the other side of the spectrum, which are working in a multidisciplinary clinic with multiple different types of medical professionals. They're referring to neurosurgeons in very small numbers, but they're also referring to orthopedic surgeons and having different consultations where they're able to demonstrate that chiropractic care works effectively. And there's so much that so many directions students are going in chiropractic school. So this is really helpful just to build context, because I believe that the majority of people I've had on this program are coming from the place where they'll take x-rays, they'll identify subluxations, they'll demonstrate effective care to people, but they're not necessarily practicing in the way that you are. And I really appreciate you just providing context, because I have been exposed to a lot of what you're describing just in some studies. I've studied a little bit of Dr. Cronk's program. I've studied a little bit of the Academy of Chiropractic and Mark Student and what they're doing. And then exploring some of what you've been providing as well. So thank you for that. Let's just keep going. So talk to the prospective students a little bit more about some of the basic fundamental skills that can prepare them maybe even before they go to chiropractic school, so that when they get to chiropractic school, they can make the most of it and really study some of the things that you believe are relevant to real world practice.
Yeah, I think so. Before you go to school, I think it would be important to look at what chiropractic is from a number of different providers, because I think whether that's good or bad, it's the thing with chiropractic is this giant umbrella. You can go to my office, an office down the street, another office down the street, another office down the street, another office down the street, and you're going to get something completely different. How you look at things, what you say you're doing, and before you get to school, it might be good to be like, that one resonates with me a little bit more. And then when you're in school, it's going to obviously mold you a little bit, right? Like when I was in school, I kept feeling a little lost because people were like, okay, here's what this person has going on. Here's how you fix it. I'm like, so does it stay like that forever? And then finally, one of my buddies was like, oh, take a look at this technique, which was CBP. And I'm like, oh, they're actually changing that. That resonated with me. That made sense to me. So I think before you go, just have a little bit. You don't need to like, study, but just maybe try to follow a chiropractor around for a couple of weeks, see if you can do that. Try to get an idea of what's happening. And I think a lot of people, certainly a lot of chiropractors, as you know, they get to chiropractic school. It's the same story. I got jacked up. Medical profession said, here's some drugs, I'm never going to get better. And then they saw a chiropractor and got them back to their life. So they already have like a pretty good idea. That's my experience with all my friends for the most part. And I think that's great. But I think then from there, if you are in that category, find out why that worked, right? Try to figure it out like, oh, this makes sense. And is it something that you want to do? So those tools are good to have to kind of prepare you, because what will change in school, or better. It better change every week, I think. Like, I learn something new every day that I can start to apply to practice. So
what are some specific resources that students should really dive deeper into, or should consistently go to continue to broaden their understanding?
So this is a shameless plug, but go to professionallyintegrated.com. That's my site. Then there's a lot of free stuff that's on there that I just post research, video breakdowns, explain it, so that you can get there and you start to become a little bit familiar with the spine, right? We have on there abnormalities of the spine, the research from all sorts of journals, Journal of Neurosurgery, of like surgeons. What's crazy is surgeons are trying to do what we're doing, but they're doing it with surgery. So if you can explain, so it doesn't matter what they're doing. It doesn't matter what we're doing. What matters is, why are they doing that, right? There's a lot of studies now. They're trying to fuse the spine into a better sagittal alignment. Well, why? Because they know that abnormal sagittal alignment leads to a lot of bad things. Those are true subluxations. Is there better options in fusing them in that position? Absolutely. But who cares what they're doing? What matters is, why are they doing it? And then try to understand that, and then try to take that with you and say, okay, they're trying to fix this structure, or they're trying to stabilize this region. They're trying to minimize the pressure on the central nervous system and the vascular system. How can I do that? And is it possible? And then you start to, realize like, oh, there's a lot that's going on here that makes a ton of sense. And here's the methods that can fix it. They're fixing it with surgery. But can we do that too? And the answer for most of it is yes. We just have to identify. And I think if you had that under your belt, of not really caring about the different modalities that can fix it, like surgery or an injection, who cares? The bottom line is, why are they doing that surgery? Why are they doing that injection? This is why I'm doing this chiropractic in my office, to fix the same true subluxation that they're trying to fix with their bag of tricks. But we can do it usually for way less expensive, way less risk, and better long-term outcomes.
So are you primarily doing full spine adjusting combined with CBP, like dental rolls or traction? How would you describe?
Yeah, we follow a good CBP base, because they have the most research to show what's wrong with the curve and how to fix it. So I've always gravitated towards that, where they're identifying true subluxations and then saying, okay, we're going to fix this. And then those subluxations of abnormal sagittal, coronal planes, or even intersegmental abnormalities are problems. It's very well published, not just by CBP, but all the research I mentioned that's on my site from spine and Journal of Neurosurgery. We know these are problems, and they have really good outcomes of how we can actually address and try to fix that. So in our office, we do full spine. We do osseous adjust. We will also instrument adjust based on each individual. Everyone is different. No one has that, just come in, we're going to really look at what's wrong with them. How can we address those problems, and then educate them on it? And then we'll do traction based on what we see. And the traction is to truly minimize, just like CBP says, to minimize the true subluxations, to fix that sagittal and coronal plane. So we're looking at globally, and we're looking at segmentally as well.
And if you're able to identify joint instability, would that be the indication that you want to switch to maybe a low force instrument, or will you still osseously adjust certain joints that you've identified to be unstable?
Well, it depends, because let's say the joint is translating posteriorly, right? It's unstable on a posterior translation. A P to A osseous adjustment could be good. But what if that joint is translating anteriorly? Do you want to do a P to A force on that? Or what if the facet joint is unstable with left lateral bending or rotation? So I'm not afraid to adjust an unstable segment that I know is there in the right direction. That's minimizing the instability. And a lot of it is also based on what that patient can tolerate, like some are like, I don't, even if we educate them on what the osseous adjustment is, it's, using an instrument in the same way that I would use my hands in the same line of drive and such, based on what their spine looks like and how their spine moves. If their joint is truly moving appropriately, I'm going to leave it alone. If their joint is not, I'm going to try to figure out. And a lot of times we'll see, instability at, let's say, C4. I don't know, I'm just picking a number. But you might find no movement below it. And okay, we're going to adjust that to get normal movement to occur in the area that's not moving, that's going to transmit stress into the area above or below, potentially causing those regions to become unstable. So the instability may be a secondary problem due to hypomobility.
Yeah, there's many compensations. Can you just talk about the clinical differences of being a physical therapist versus a chiropractor? If we're talking to a college student, they're thinking, maybe I'm going to go to physical therapy school, or that's my goal, but maybe they're feeling there's too much competition to get in, or maybe they just have never considered chiropractic. Can you help really kind of bridge the gap on how chiropractors are different from physical therapists, but make it still an attractive thing?
Yeah, I think like what my uncle told me 25 years ago when I was looking at school, or more than that, was PTs, chiropractors, if you want, can do everything a PT can, but PTs cannot do everything a chiropractor can. And I think PTs are good at, like, giving some exercises and strengthening, but they're not getting these joints to move like we're supposed to, or truly changing the mechanics of the spine. I do feel like I would get bored. And again, look, there's different types of PTs, right? That the physical therapists that are working with people that just had strokes in the hospital, and, quads, or, man, they do some amazing work. Like, you need people to have a PT for someone that just has, back pain or neck pain. I feel like they're so limited compared to what we can do. That's my personal opinion, because I'm like, okay, you can strengthen them, you can stretch them, but what do you do to improve the mechanics, the shape, and the movement of that spine? Exercises, like, it's going to help. But I feel like personally, just being a PT for the things that we see is like exercising, but still eating a bunch of fast food. Like, it's okay for you, but man, you're leaving a lot out.
Yeah, no, I hear you. Listen, I really appreciate you taking the time to share with prospective students here today. There's a lot of great insights, and just giving them a glimpse into the way that you're making the most of this experience of being a chiropractor. It sounds really cool. And if anybody wants to connect with you, I'm going to definitely post a link to your website below, and definitely just share some of your contact information. Any last messages that you want to share with pre-chiro students out there?
Yeah, I would say do it. I don't regret it at all. And I think also take your blinders off and look around, and don't be afraid to ask questions. Don't be afraid to ask docs questions, right? If you feel like, oh, that person's going to get angry with the question I asked them, then they're not secure in what they do. And that's the beauty of being a student. You need to ask these questions. But if you're a student who gets mad or irritated at a provider because they're trying to give you information, or they can't explain why the information that you're touting is correct or BS, then you need to quit, right? Like, you're too sensitive, you're too soft, you're too afraid. This is you're going to be a healthcare provider. And what we know today will probably be different than what we know tomorrow and in 5 years. And if you are asking a doc, like, hey, you say you can do this. Well, how do you know? And if that provider can't answer, or they get mad, as opposed to encourage and be like, oh, let me show you, let me explain this, then you might want to look for another provider to ask, because what you do is going to change the lives of many people. And knowledge is power, and asking questions should always be encouraged. But again, if you're a provider or a student that is upset with a provider giving you information because it doesn't follow the path that you and your classmates are following, then you need to really evaluate who you are. And it's going to be a long, hard road when you get out, because if you think another doc, a friend, is asking you difficult questions, wait until a patient does.
Mm-hmm. Mm-hmm. Very cool.
So keep
Thank
exploring. Yeah.
I know you could keep flowing. I just want to acknowledge your time, and I got to roll, but thank you so much. I really appreciate you, man.
I appreciate you too, man. I'll talk to you later.
Absolutely. Have a great day. Happy Thanksgiving.
Yeah, you too. Thank you.
Peace.